I'm just going to go ahead and mute some folks, but please do take a moment and mute yourself upon entry. The structure of our session today is in the ECHO format, and we'll be starting with some announcements, introductions, and then we'll follow that with a brief introduction for 40 minutes. Today's topic will focus on the follow-up for cognitive impairment if your patient screens positive. And then we'll move on to a brief case presentation and then have some closing and reminders. So just some house rules, just to make sure our session runs smoothly. You have been muted on entry, but please just be cognizant if your microphone is on to limit conversation. If you do wish to speak and participate in our discussion today, feel free to unmute yourself and introduce yourself with your name and location prior to speaking. We do want to maintain confidentiality if speaking about any of your patients or clients and refrain from using specific information about them, and of course, respect others and their opinions. As you know, our sessions are CME accredited, and our main objective is to educate the community and rural healthcare providers in aging and elder care, treatment and management, and of course, to expand access to geriatric specialty care throughout California.
What's the SR code?
Our target audience is you all and anyone with an interest in the care of older adults. Today's session is accredited for one.
Oh, that's part of your endo data gathering.
Again, please do mute yourself if your microphone is open. If you do attend all sessions in our series, you'll receive a total of 6 CME credits, and CME certificates will be sent to you by our CME office at the end of the series, and we'll outline the total number of hours attended. Many other licensing boards, like the California Board of Nursing, does recognize CME for reciprocity. Our series is part of the Geriatrics Enhancement Grant at UCI. And again, our goal is to train primary care providers, healthcare professionals, and trainees to expand this workforce. And again, we truly appreciate your time in joining us this afternoon. So let's move on for some introductions. We would love it if you would introduce yourself in the chat. And if you could please include your name, your location, your role and site, we would appreciate that. In just a moment, we'll have our hub team introduce themselves so that you can get to know us a little bit better. So go ahead and use the chat function and let us know where you are coming from. So I'll get us started on introductions. My name is Sonia Sagel, and I'm a clinical professor here in the Department of Internal Medicine and the Division of Geriatric Medicine and Gerontology. And my area of interest is healthy aging. My practice sign is in orange at the Senior Health Center. I'm going to turn it over to my colleague and friend, Valerie George.
Hi, everyone. Welcome to our ECHO series. Nice to meet you. My name is Valerie George. I am a physician assistant. I work at the Senior Health Center in Orange with Dr. Sagel and taking care of geriatric patients. So welcome.
Thank you, Valerie. I'm going to also hand it over to Dr. Manisha Pereira.
Hi, everybody. Welcome. I'm Manisha Pereira, one of the geriatricians at UC Irvine. I also practiced in Orange at the Senior Health Center. Welcome. Thank you.
Thank you, Dr. Pereira. Again, I do hear an open mic, so if your microphone is open and you are speaking or have any background noise, please do go ahead and quiet that.
Well, you can still see it on there and just hear it on here. Yeah.
So right now I see an open mic from Evelyn Gonzalez. If you could just mute yourself, we'd appreciate it. Thank you. All right. So today's topic is about cognitive impairment and what to do if your patient screens positive. And I will just go ahead and jump right in. Our agenda for today will be talking about aging in America very briefly. I'd like to put this in context for our aging population. I'm sure that you're all seeing in your practices at your sites that the number of older adults coming in has grown over the last 10 years. And if you haven't seen it, I'm sure you will in the future. And we'll talk about some data in that regard. I'd like to introduce briefly a program that we have adopted here at UCI and a project that we've been participating in that's centered through UC San Francisco, a project called Dementia Care Aware. And so I'll briefly introduce that, and that's a mechanism for implementing screening in your practice. I'll then talk about a symptom-based workup for cognitive impairment, and we'll talk about some considerations when disclosing the diagnosis. We have several subsequent sessions scheduled for you, either on a Wednesday or Friday afternoon. And topics to follow will include the management, both pharmacologic and non-pharmacologic for cognitive impairment. We have specific sessions on medication-related issues, and actually several sessions on deep dives into the specific types of cognitive impairment, the four more common types of dementia: Alzheimer's, vascular, Lewy body, and FTD. So please do look forward to those presentations coming right up. So let's go ahead and put this in context, and let's talk about some of the trends that we're seeing among our aging population. So here in Orange County, where I practice, by 2040, almost 1 in 4 people in Orange County will be over the age of 65. So 25% of our population. And of course, you know, this is for a lot of reasons this is occurring, but you know, we are seeing a change in life expectancy, and by 2050, life expectancy for both men and women will be over the age of 80.
Oh, this is mine, right? Yeah.
Again, we do have an open mic, so please mute yourself if you note that you are. I can see that Evelyn Gonzalez, please mute yourself. This figure here shows the projected population growth increase for people over the age of 65 compared to other age groups. And you can see here that this line in orange that I've circled, this represents the age group over 65, right? And you can see that this line, this bar, is the only one with an uptrend. So all other age groups really are either flat or decreasing. And this, again, is just evidence to show that in our practices, we will be seeing more and more older adults. You know, and this data that I've presented to you here is for Orange County, but really you can generalize this across America. The US population for the first time in people over the age of 65 is expected to outnumber young adults and children. And you can see this here in data put out by the United States Census Bureau. So along with our aging population, conditions that occur more commonly in the elderly are, of course, expected to bloom. And this is a study that was published years ago in the Archives of Neurology, and it approximated that for those individuals over the age of 85, there was a prevalence approaching 50% of some form of cognitive impairment. And with our population expansion, the way we expect, and that we're seeing and we expect to see further, we anticipate a very high burden of cognitive impairment in our clinical practices, and of course, impacting society and patients. So of course, screening for cognitive impairment is important. It's important for a lot of reasons, but we often miss the symptoms, especially in patients that we know well and we've taken care of for a while. And although I participate in a comprehensive geriatric clinic where we do very formalized cognitive testing, I'm often surprised to know that some of my long-term patients who I would not suspect to have some form of pathologic cognitive impairment do show objective evidence of impairment on screening. So again, you know, approximately 50% of people over the age of 85 have some sort of cognitive impairment if you take that study at face value. And in 1995, Callahan demonstrated that dementia was recorded as a diagnosis for less than 25% of people who had a moderate to severe impairment. So I hope that since 1995, our ability to detect and treat patients with a moderate level of impairment has improved. Although I worry because we are so burdened and busy in our practices that often screening falls to the wayside. So again, just a real push to emphasize that the population is aging, and along with that comes a huge burden of cognitive impairment, which is more common in this age group, and that we really should be doing more to screen and recognize. Now, as I alluded to before, at UC Irvine, we do participate in this program called the Dementia Care Aware Program, and I hope that you'll take a moment and look up this Dementia Care Aware Program online. It is a training opportunity for you to become familiar with a screening modality that is validated. It's a 3-step process. You can actually go through formalized training online through an online training module, or you can participate with us. We do offer a Zoom-based training as well. And it's great for all primary care clinicians to think about implementing a screening program like this in your office. But if you do see Medi-Cal only beneficiaries that are over the age of 65, you actually, after certifying with the training, you actually have an opportunity to bill the program. You can bill Medi-Cal for your work. And this is what the online training module looks like. And it's the dementiacareaware.org website that I would refer you to. And just as a brief intro, there is a 3-step cognitive health assessment that we recommend in your clinical practice. So if you're not already screening, you certainly can think about using this as a modality. So the 3 steps are: 1, taking the patient history, taking a very brief history. This is, again, screening, so you don't have to get into all the details of a cognitive history, but just some very basic history. You can use validated tools for assessing cognitive and functional decline, and then you establish a patient support person or healthcare agent. And if the patient screens positive using a validated tool, it could be a mini cog, it could be a GP cog, it could be a MOCA, it could be an MMSE, and maybe you would assess for ADLs and IADLs. If your patient screens positive, you then would move on and launch into the what next. So your patient has screened positive, what do we do? And that's really the focus of our talk today. So if you've screened using some tool, you've assessed function, maybe you've done the cognitive health assessment, maybe you have another way of screening in your office. What do we do? What do we do next? So to get us started, I wanted to briefly introduce a few cases. So case number 1, we have a 76-year-old female who's coming in with her son and daughter. Past medical history is significant for severe right knee arthritis and hypertension, and she's had a slow and progressive short-term memory loss. She forgets to take her medications, she's forgetting details of her medical visits, and despite all of that, she's able to perform her activities of daily living without assistance. And she reports, and the family agrees, that she can independently complete her instrumental activities of daily living. And the family feels that whatever changes that she's going through are consistent with a normal aging process. So if you saw her in your office and initiated a screening assessment for her, simply because she came in for an annual wellness visit, maybe you noticed some cognitive changes in her, you could take a brief history. That would be the history I've presented to you. You could use some tools to assess cognition and function. And in this case, we did a mini cog and she scored 0 out of 3. And her activities of daily living and instrumental activities of daily living were assessed briefly as part of the history. And her son and daughter are her support people. So with a mini cog of 0 out of 3, she has screened positive for some degree of cognitive impairment. And now we need to decide what to do next. Here's another example. So we have a 76-year-old female who's coming in with a history of diabetes and hypertension, and she has actually a subjective complaint of memory impairment. So she's actually worried about her memory. She lives alone and manages her bills and finances without issue. So, functionally, it looks like she's doing pretty well. She forgets details of conversation and names of people that she meets. And she's able to perform her activities of daily living without assistance. She has some mild word finding difficulty, and her husband died 2 years ago of COVID-19. So you perform the same sort of screening assessment. You did the history as I presented it. Her mini cog is 3 out of 3. Her activities of daily living and instrumental activities of daily living were assessed as part of the history, and they're intact. She has no support person and she lives by herself. So you can see in these two cases, right, the what next here might look very different. And the ultimate diagnosis for these two individuals may look very, very different. So let's use this as a launching board to talk about the differential diagnosis of cognitive impairment. And I know that you guys are all familiar with the variety of medical issues that can contribute to cognitive loss. And, the way I've broken them up here on this slide is either neurodegenerative or not. And under the neurodegenerative category, I've listed the 4 more common forms of dementia. So Alzheimer's, vascular, frontotemporal, and Lewy body. Of course, there are others that are more rare. But the 4 here are the ones I think that you should be most familiar with. And I think if I, talked about Alzheimer's disease in a little bit more detail, you would agree with me that patients with Alzheimer's dementia present with a slow and progressive short-term memory impairment. They can have some word finding difficulty. And these patients in general do not have self-awareness of their cognitive loss. Vascular dementia, these individuals generally have some vascular risk factors, hypertension, diabetes, maybe they've had a stroke in the past. Their cognitive loss tends to be more patchy, can occur stepwise, and sometimes these individuals may have an awareness of their gaps. Patients with frontotemporal dementia, and there are a few different variants of FTD. These individuals present with mood and personality changes. They can look very disinhibited, become hypersexual, have some hyperorality, and executive dysfunctions. And then there's Lewy body, of which the hallmark is very vivid visual hallucinations, and they can look like they have, Parkinsonian features. So there might be some rigidity, shuffling gait, flat faces, and the like. In subsequent Zoom sessions and subsequent echoes, we will go through each of these individually in a great deal of detail. Now, aside from these, 4 more common kinds of neurodegenerative issues that are in the differential diagnosis, there are other diseases, there are other conditions. And so thyroid dysfunction, hyper or hypothyroidism can contribute to cognitive loss. We often see vitamin B12 deficiency in our older adult patients, which can contribute to cognitive loss as well, and fatigue and even neuropathy. We do see a significant percentage of our patients with depression and adjustment disorder due to for a variety of reasons. And often these individuals can have problems with attention and concentration, which makes them appear that they can sometimes appear to have a neurodegenerative disorder. But if we're able to treat the depression adequately, cognition can improve. Patients with NPH can have some cognitive issues associated with urinary incontinence and a gait impairment. And then, of course, alcohol, substance use issues, sleep apnea, HIV, neurosyphilis, and certain medications can also cloud the picture In my practice, I have seen very recently an individual with significant alcohol use disorder having episodes of blacking out, families concerned that he has dementia, and actually brought him in for a dementia workup. On very formalized cognitive testing, he scored completely normal. It was simply that he has an alcohol use issue, which is causing him to have complete chunks of time just blacked out. So again, please do keep these issues in mind when you're evaluating your patient who's screened positive. Now, when we make the diagnosis, or we attempt to make the diagnosis of cognitive impairment, of course, we're going to take a complete history. So on screening, you might ask, are you experiencing any memory issues? Has someone noticed that you have memory issues? But when you dive deeper, there are a whole host of questions that we'll get into. We do pay particular attention on physical exam to our neuro examination. We also assess for hearing and vision. And as you know, hearing loss is associated with cognitive impairment. And if someone can't see or hear adequately, that might lead to them not being able to acquire and consolidate information appropriately. We recommend, obviously, a cognitive evaluation. If you're doing this in your office, you might choose to use a MoCA, an MMSE, a GP cog, SLUMS, some form of validated screening tool. And often, you might perform the evaluation, at time point number 1. So you might do it today. You might find that the patient has they score lower than anticipated. You then send them for labs. Maybe you send them for some assessment of their mood. And you can't really make the diagnosis right away, and that's okay. Often the diagnosis of a dementia or significant pathologic cognitive compromise takes some time, and we will bring them back at three months and re-administer, or 6 months and re-administer, and track over time. And only does the apparent condition that's underlying the change then become apparent. So you do have to be patient sometimes and perform serial cognitive evaluations. We would also then assess for conditions that mimic dementia. So depression and delirium are the two that we highlight here. We'll talk about some laboratory testing. We would then consider brain imaging, but not necessary in every single patient, and assess reversible causes. So the way we would move stepwise in making the diagnosis. So complete history, physical examination, serial cognitive evaluation with a validated tool, and then look at reversible causes. So depression, delirium, medications, and then assess labs, question brain imaging if needed, and then do a final assessment of any reversible causes. So when you're thinking about the medical history for someone that has cognitive impairment, my colleague shared this mnemonic with me, NW-COMS, and it's great for you to just sort of think about. I know some of our trainees have this as a template in their EPIC portfolio. So they just go through and will ask patients these things. So the nature of the complaints: are they forgetting appointments? Have they gotten lost? Are they misplacing things? Issues with word finding, missed payments, affect, language, behavior changes, any hallucinations, agitation, or depression. You want to know the time course. Did this occur very abruptly? So maybe if it occurred abruptly in the setting of a UTI or a hospitalization, maybe delirium is higher in the differential. If it's occurred over decades, years, slow and gradual, maybe that's Alzheimer's. If the course is abrupt or stepwise, maybe that's consistent more with a vascular component. If function is impaired, you want to assess that. You want to look at the living situation. So our older patients experience a great deal of loss, personally, socially, physically, and that should be looked at as well. So bereavement, who's in the home with them, have they moved recently, any loss or turmoil in the family could contribute. What their mood looks like: are they having anorexia, insomnia, anhedonia, depression, and then of course status of their health. So thyroid, electrolytes, maybe a UA to look for a UTI if symptoms point you in that direction. So we would do the cognitive history as I presented in the prior slide, and then of course look at past medical history. Are there vascular risk factors? Has there been a brain injury? Maybe they were a football player. Maybe they had a job site related injury. They were involved in, a head injury after a significant fall or motor vehicle accident. If they've had any surgery recently that could lead to delirium, or any surgery that might have led to an anoxic brain issue like a bypass surgery or something like that. If they have a family history of dementia, we always ask about that. We review their medications in detail, look at their social support. So who is helping and assisting them at home, and do ask about driving and firearms. If there are firearms in the home, we want to make sure that those are locked up or put in a safe place. And then we look at the review of systems, and we look at things like gait imbalance, falls, tremors, incontinence, weight loss, headache or blurry vision that might lead you to think about, a space occupying lesion, any asymmetric weakness for stroke, rash, insomnia, etc. So all of these things that we're looking at are pointing to one or more of the items on the differential diagnosis list. When we think about the physical examination, we are observing initially for involuntary movements. Sometimes we'll actually bring the patient in from the waiting room to the examination room ourselves, because we want to watch their gait to see if they're shuffling, if they are holding onto the wall for stability. Maybe they have more of a magnetic gait or a wide-based gait, or they're not moving their arms, or their arm swing is impaired. Maybe that's going to let us think about NPH or Parkinsonism and move that up on our differential diagnosis. We look for involuntary movements during our conversation, the speed and fluency in which they're speaking to us, and their facial expression, eye contact, and whether they're making comments that are disinhibited. So we sometimes will see patients come in and they'll make inappropriate remarks that really kind of make you wonder if they would have done that if 5 or 10 years prior, if they did not have some sort of a cognitive issue. On the neurological exam, as I talked about before, so we're looking for asymmetrical deficits. So maybe trying to see if the patient has had a stroke that went undiagnosed. And I'm surprised often by how many times that we find that on physical exam. So if there's weakness, if they have issues with deep tendon reflexes or a Babinski, maybe we're thinking about that. We'd look at visual field abnormalities and do a very good eye exam. There are some forms of cognitive impairment like PSP where patients can have some difficulty with eye movements. Again, we look for signs of Parkinsonism, so tremor, rigidity, flat face, shuffling gait. We're looking, maybe the patient has a Parkinson's disease and they haven't been diagnosed, or it's very early, or this is Lewy body. We look at neuropathy, which might be a clue for vitamin B12 deficiency. And there are some other physical exam findings that you can see in patients who have very advanced Alzheimer's disease. But this is sort of the basic neuro exam that we would launch into for our patients after someone who has screened positive. Now, in terms of the workup, so in terms of looking at laboratory data, the American Academy of Neurology recommends a CBC and a vitamin B12. A B12 and TSH will evaluate for potential reversible causes of cognitive impairment, as we had talked about before. In regard to looking at someone's neurosyphilis risk, the RPR, we generally reserve that for patients with risk factors for neurosyphilis, and an HIV test might be indicated for patients in this category as well. And then we would look at neuroimaging. So, does your patient really need to have an MRI or a CT scan? And I think, if imaging is readily available to you or your patient, I think it's okay definitely to get and make an assessment. We do consult with patients who have very limited resources or clinics who have very limited resources, and it's challenging to get an MRI. And for situations like that, we often will recommend that if a patient very classically presents as an Alzheimer's disease picture and their neuro exam does not lateralize, so they do not have any signs or symptoms of an abnormality in that neuro exam, sometimes we'll forgo the MRI for the moment because of the challenge in getting that. Of course, if someone does lateralize on an exam, has an abnormal neuro finding, or has a very early onset picture, we would recommend getting some form of neuroimaging. Also, if they have any red flags, so if they have a history of, a bleeding disorder, a head injury, a malignancy, the threshold to send somebody for cognitive testing is a lot lower. So when we think about making the diagnosis, we complete the medical history, we focus on the physical exam, as I've mentioned. We think about doing our serial cognitive evaluations and then review medications. We review the further differential diagnosis, labs, imaging, and assess reversible causes. Now, I wanted to highlight serial cognitive evaluations. So often in clinical practice, at least for me, because I'm in a hurry or I have limited time, I'll often turn to the mini-cog as a screening modality. So as you'll recall, the mini-cog is a 3-item recall, right? So 3-item recall with a clock draw. And it's a very simple, easy, and quick test to administer. And it's actually validated, right? So we tell the patient, here are 3 items, apple, table, penny. You give them the distractor task of asking them to draw a clock. And then you ask them, okay, what were those 3 words again? So if someone screens impaired on the mini-cog on examination, maybe I'm doing this during my annual wellness visit, maybe I've done this as part of an annual physical, and they screen positive, I would then bring the patient back for another visit and go through a very detailed assessment. And I would go through the questions that I went through in the cognitive history. I'd look at the past medical history, family history, et cetera, specifically looking at risk factors for cognitive impairment. I would look at medications. I would look at the neuro exam very carefully. And then maybe I would choose to administer on a follow-up visit another examination. So something a little bit more detailed, like a MOCA, where attention and concentration, executive functioning, memory, language, et cetera, all of these cognitive domains are being assessed. And if I do that and I find some form of deficit, maybe their score is lower than anticipated or low, I could then either make the diagnosis if I was confident, or I could bring them back at 3 to 6 month intervals and re-administer the MOCA and see how the patient does. So in our case number 2, the lady who had lost her husband due to COVID and was living alone, I'm sure you were all thinking, okay, well, maybe this lady has some, she's experienced some loss. She has a subjective memory complaint. Maybe this looks a little bit more like depression, right? Causing some attention and concentration deficit. So maybe you opt to treat her depression. Maybe you administer the geriatric depression scale and you treat her depression, and 6 months later or 3 months later, you re-administer the MOCA and you see how she does. And maybe her score improves and you continue her down the line of treatment for her depression and you administer the MOCA again. And you see improvement, and maybe the individual now has a score that is within normal limits and her subjective complaints are improved. So that would be one way to administer serial examinations. Another might be for an individual that has experienced a hypoactive delirium or is delirious from a recent hospitalization or surgery or infection. And so maybe the family brings the person in and they're concerned. You recognize that this abrupt onset of cognitive change with fluctuating levels of attention is not really in line with a neurodegenerative disorder. You check the labs, you check everything, you treat the infection or the underlying cause, and maybe at serial time points, you administer the cognitive evaluation, and you see if they progress, if they get better over time, or maybe they get worse, or maybe they stay the same. And a clinical example that I have for that is actually, I had a patient who over Christmas of 22 was diagnosed with influenza and pneumonia and was hospitalized for 4 days. And pre-admission, pre-infection, he was functioning, quote, normally by the family. So he was admitted and he came out of the hospital and recovered from his infections, but his cognition took a hit. He was very slow to respond and had trouble doing calculations and things that he would normally do. We did the entire evaluation. We did the history, the physical examination. We looked at reversible causes and checked labs. Because this was more of an abrupt onset, we did get an MRI. Everything checked out. There was nothing of concern there. We administered a MOCA. He was obviously impaired, and over a 6-month span, administered the MOCA 2 more times, and his score significantly improved as his delirium lifted. It took a very long time for his delirium to lift, but his score did improve. So another example of how to do a serial follow through on someone that you're concerned about with cognitive impairment. Now, the MOCA is just one tool. You could use an MMSE if you like. There's also something called the slums. I find people are less aware of the slums. Similar tool, probably takes about 10-15 minutes to administer, the same as with an MMSE or a MOCA. Slums has been translated into several different languages. You can look up online. If you look up the slums examination, you can find it. I think it's been interpreted and translated into about 20 different versions for you to use on non-native English speakers. Now, patients often ask me, who needs a very formal assessment by a neuropsychologist? Who needs to go in for, this 3-hour testing? And how do you make that decision? Our subsequent session in this series will talk about that in a lot of detail, but just generally speaking, formalized neuropsychological testing, again, is not required for every single patient. We do like to use it in individuals who have a very high education. Sometimes they will find the MOCA or the slums very, very easy, and we're not able to detect cognitive decline because their baseline was just so very high. So individuals with a high education, certainly in younger individuals, we might choose to use this. And if we're really trying to differentiate, maybe you have someone with very mild impairment and you're trying to distinguish between how much is actual cognitive neurodegenerative change versus a depression, for example, and you've treated the depression and they're still impaired, maybe neuropsychological testing would be appropriate in those situations. But before sending anyone for formal neuropsychological testing with a neuropsychologist, I would make sure that I've evaluated all of my reversible causes. I've treated or managed delirium and depression as best I can, because of course, those will cloud the test scores that the neuropsychologist will perform. And generally, I like to wait at least a month to 3 months or more after someone's been hospitalized to make sure that any residual effect from the hospitalization has lifted. So really you want your patient to be at their cognitive best when they present for their formalized testing. This testing does take up to 3 hours or more. So for an individual who has moderate level impairment or approaching moderate level impairment, they may not be able to sit through this kind of evaluation. And you might not need it if they're that impaired. I think when individuals become to the stage of moderate dementia, it's often hard to tease apart the specific etiology of their neurodegenerative condition. And so sometimes neuropsychological testing isn't as useful in those cases. Now, I've alluded to medications and their impact on cognition. And as you know, there are so very many medications that can negatively impact cognition. And a few of them are listed here. We are very aware of any medication that has an anticholinergic property. So things like diphenhydramine, hydroxyzine, PM medications that people take for allergies or to help them sleep at night. Of course, benzodiazepines, sleep aids like Z drugs, muscle relaxants, even certain cardiac drugs. I mean, there's a whole host that can cause cognitive impairment. So it is worth doing a very detailed medicine reconciliation, looking for cognitive issues. We saw somebody recently in my practice, and they were on amiodarone and Pepsid, and our pharmacist was concerned that there might be a potential contribution to these commonly used medications, but that they might negatively be impacting this individual's cognitive profile. So really look at each and every medication very carefully. The other thing that we've started to ask about in our practice is cannabis use. So as you know, cannabis is used quite widely actually in the older adult patient population. Often they don't disclose it. There is no place to disclose it on a routine medical history or paperwork, at least in our office. And so we do ask about that. And of course, alcohol or other substance use. So this table just is a reminder of the things I talked about before. So when you're assessing cognition and you're going through the history and physical examination, and you've ruled out these potential reversible contributions to cognitive impairment. So you've assessed for mood, you've assessed for medications, you've looked at delirium, and maybe you're starting to think that, maybe there is a true dementia neurodegenerative process happening here. Again, just as a reminder, some very basics about the 4 more common kinds of dementia, right? So Alzheimer's, that's the most common form that is recognized in terms of dementias. We certainly see it the most in our practice. These are patients who experience a gradual decline in cognition. These are mainly memory dysfunction, short-term memory impairment with a normal neuro exam. Lewy body, the patient that may be having visual hallucinations, Parkinsonism, vascular, so stepwise decrease, and maybe they're lateralizing on the neuro exam. And then FTD patients, these tend to be younger individuals, behavior changes, language issues, and disinhibition. And this is the dementia that you may have heard about in the social media and in the press recently. So this is the kind of condition that Bruce Willis was diagnosed with. So again, just in terms of the stepwise process here, this was a graph shared by one of my colleagues, Dr. Stephen Tam. He developed this in terms of coming up with the workup and treatment for memory loss. And it's just a nice a flow sheet that you can follow. So basically, if someone comes in with memory complaints, maybe you screen them and you've picked up the memory complaint, or they come to you with a memory complaint. You then launch into the workup, which would include the history and physical, and you look at not only the time course and all the details of cognition, but you look at their function. So you're assessing for activities and instrumental activities of daily living, looking at their medications, family history, relevant social history. You perform the physical exam. And if you have not already initiated some form of cognitive screening or cognitive testing, you do that. So you use your validated tool. You then look at your labs. You can look for reversible causes here. So, and other contributing factors like a metabolic panel, blood count, thyroid, B12, HIV and syphilis if required. You would consider your CT MRI to evaluate for stroke, structural changes, if your physical exam was consistent with that. And he's listed here the possible reversible causes for you to think about. So maybe there's a metabolic disturbance, an endocrine or thyroid problem. Maybe there's an infection leading to delirium. Maybe there's a substance use issue, sleep, mood. Maybe there's a psychiatric condition going on. And then you can classify patients. Maybe your individual has screened normal. Maybe the testing and labs and everything that you've done, everything is normal, and they have a subjective cognitive complaint. If that's the case, maybe you bring them back, you reassure them, you bring them back, and you encourage them to stay active and avoid medications or substances that would interfere with their cognition. You manage vascular risk factors very tightly. Maybe you diagnose them with a mild cognitive impairment. And a mild cognitive impairment is the kind of in-between state between normal cognition and a full major cognitive disorder or dementia. And these individuals generally have some subtle change in memory. Maybe they do have they've lost a few points on cognitive screening validated tools, but they're able to function completely independently, and their instrumental activities of daily living and their activities of daily living are intact. If that's the case, you treat for any coexisting condition that they might have, any reversible causes, and you monitor these individuals at 3 to 6 month intervals, and you closely pay attention to any further decline and their function. Maybe so that would be kind of the middle state there. And then maybe you do this entire workup. The patient does have points lost in cognition. They're not able to be independent with their instrumental activities of daily living. In this case, now you're really starting to be concerned about a major neurocognitive disorder or a dementia. Again, you treat any coexisting conditions. You encourage the patient to stay active. You avoid medications that would have a negative impact. If you're thinking that the patient might have Alzheimer's because they look very classically like an Alzheimer's patient, you can consider starting a cholinesterase inhibitor or an NMDA receptor antagonist, and then following up thereafter. And we'll have a presentation specifically talking about drugs and their use and indication for patients with cognitive impairment. But all the while, you would be treating any mood issues that they have. If they have behavioral issues, you want to make sure that the family is well supported and educated about how to manage somebody who has a significant cognitive deficit. You can adjust their environment and, of course, assess for safety and driving, and talk about advanced care planning. Now, somewhere in here, you might say, okay, well, when should I send this individual to a neurologist, right? What is the role of a neurologist here in managing someone's cognitive impairment? So, primary care clinicians that I've worked with in the past at some health systems have shared with me that it's often hard to get someone into neurology, that the wait time can be months, weeks to months, and that the neurologist might corroborate the diagnosis or make the diagnosis, but then is just simply too busy to follow on a regular basis. So with that feedback, we've really been we've really given a lot of thought to the type of patient that would benefit from a neurology referral. And so for any individual that has unusual or atypical findings, maybe they have had a significant personality change. They're very disinhibited. They're very young. They're in their 40s or 50s. Maybe they have an abnormal neurological examination, and you're trying to distinguish between Parkinson's disease and dementia and Lewy body, and these are very high in your differential. I would definitely recommend sending to a neurologist. There are now some FDA-approved medications that have very specific indications. I'm sure you've heard of lecanemab and aducanumab, and if your patient is thinking about a clinical trial, wanting to enroll in a clinical trial, you might consider a neurological referral for them. But I think a lot of it depends on your health system. All right. So just going back to our original 2 cases that we talked about, right? So our first case was the 76-year-old lady who had the knee arthritis, 2-year slow and progressive short-term memory loss. She was forgetting to take her medications. She was forgetting details of medical visits, vague with her responses. So she was showing some slow and progressive short-term memory impairment. Her activities of daily living were intact. Her IADLs were intact. So you assessed her, you did a mini cog, she was 0 out of 3. Her ADLs and her IADLs were assessed as part of the history. You noted that her son and daughter were her support individuals, and you could very nicely use the table here to work through her situation. So she had a memory. She came in for one thing, you noted memory issues, you did the history, you did the labs. She was 0 out of 3 on her validated screening tool for cognition. You could then go through and assess for reversible causes and find where she would fit here. In her case, she actually scored 0 out of 3 on cognitive testing. We took her family's word for it at face value and said that, okay, she's intact with her IDLs and ADLs. We brought her back in short follow-up for a subsequent visit, got more information. In fact, she was not intact with ADLs and IADLs. Her family just really didn't want to disclose that. And she was having significant cognitive impairment, required almost 24/7 supervision, and was ultimately diagnosed with a major neurocognitive disorder or dementia of the Alzheimer's type, and was started on Aricept and Namenda for that, and then followed serially until she moved into a memory care unit. For our other patient, who was 76 with a history of diabetes and hypertension, she came in with a subjective complaint of memory impairment. And she was able to perform her ADLs and her IADLs, but described some mild word finding difficulty. As you recall, she scored 2 out of 3 on the mini cog, and her ADLs and IADLs were intact. So going through this flow chart for her, she had a memory complaint. We worked it up extensively. We looked at her labs. She did not lateralize on physical exam, so she never got a CT or an MRI. We looked at potential reversible causes, and on further review found that she was depressed. She was treated for her depression and then re-examined. So she had her cognition re-evaluated with a brief screening tool. And as her depression lifted and was adequately treated, she fell back into the normal category. So she was actually diagnosed with major depression, treated, and provided with support resources for her. So 2 very different trajectories for these 2 individuals. So again, we want to identify reversible causes, very important, as demonstrated by that second case. We want to optimize blood pressure, blood sugar, and if someone does have a neurocognitive disorder and they're showing kind of advanced symptoms, we want to think about non-pharmacological methods for management. So really making sure they have a good structured environment in which they're residing with a great deal of safety and oversight. We want to treat any concurrent disorders. So if maybe they have untreated sleep apnea, and we want to make sure that they get an assessment and are adequately treated. Maybe they're using a benzo for anxiety or insomnia, and that's clouding their ability to have normal cognition. So we want to treat that adequately and withdraw them from any offending agent. We want to think about drugs, and then of course supportive care and planning. Now, in my own clinical practice, I have a lot of challenges when we talk about dementia management, and I'm sure that all of us kind of experience this, right? It's hard to conduct these serial evaluations over multiple visits, but I do find it's most practical to do it that way. It's hard to get everything done in a 20-minute visit or a 15-minute visit, certainly. If you have the opportunity to engage your support staff, it's extraordinarily helpful. So maybe your support staff can administer the GDS, or maybe they can perform, the MOCA or the MMSE for you. That's very helpful. And then you can interpret the results and make the formal, kind of follow-up plan. I definitely encourage the use of the electronic health record for efficiency. So if you have templates for cognitive screening or smart phrases that you can use, very helpful when it comes to documentation. And just remember that dementia is a syndrome. So it takes a lot to make this diagnosis and to confirm this diagnosis, but no one thing is going to do it for you. So a patient can have a very abnormal MRI and be completely cognitively intact, right? Or be very, very, very demented and have a normal MRI. So no one lab, no one imaging, no one thing is going to kind of clinch the diagnosis for you. This is a syndrome, and history really is the key. So take a lot of time when you are sitting down with somebody to get that information. And oftentimes we do have to call a support person or confirm with a support individual these features. So if you have noticed that someone scored poorly on a screening assessment, or you've noticed something, or they're coming to you with a cognitive concern, again, just think about how you're going to communicate your findings to the individual. Really important to bring people in with a lot of time to conference about what you think might be happening. And maybe you don't know if they have dementia or not, or they're depressed or not, but having that conversation about your concerns, I think, is very important. So think about separate appointments, think about your compassionate communication strategies, and be familiar with resources in your community. So we rely very heavily on the Alzheimer's Orange County and the Alzheimer's Association. They have incredible resources and support for your patients and their families. And then, of course, set expectations. So, let them know this is something that requires ongoing evaluation, and you may or may not be able to confirm the diagnosis at this time. So just a couple of things. So if it's a first-time visit for memory, you're going to do all the things that we talked about, do all of the assessment that we talked about. And then, of course, bring them back 3 to 6 months or sooner if they need to be seen sooner, or maybe you've started a medication and want to bring them back sooner, but you want to just continue to reevaluate any changes in their history, changes in medications, and then consider serialized cognitive testing. And then, of course, review for safety as things progress, or maybe they'll get better. So again, I wanted to just highlight what's coming up next for you. So this was a very generalized overview of what to do next for your patient that screens positive. So you're going to, think about these steps in the history, physical, and look for reversible causes. In subsequent sessions, we're going to do deep dives into medication management. So maybe you do suspect that your patient has Alzheimer's and you're wondering when and how to initiate medications for that. So we'll have a session focused on that. We have sessions focused on behavior management and resources. I believe our next session is focused on neuropsychological testing and really when to engage your neuropsychologist. We have presentations coming up on cultural considerations, and then, of course, deep dives into the 4 more common kinds of major neurodegenerative disorders. So with that, we are almost out of time, but I'm going to open it up for questions. And if you have any feedback for us or would like CME, please don't hesitate to use these QR codes here so that you can get credit for your attendance today. So with that, I'll open it up to any questions.
Thank you, Dr. Sagel. I see in the chat there's a question from Dan Mercola. You mentioned prescription like cholinesterase inhibitors. What's your opinion of the efficacy of current prescriptions?
It's a great question. Oh, I thought there was an echo there for a second. That's a great question. So in particular with the acetylcholinesterase inhibitors, right? So if you look at the studies that were done that moved these drugs through the FDA, there was a few points of an improvement on on the MMSE, for example. So maybe, the patient scored, I'm just making up some numbers here, but maybe they scored, 20 on the MMSE, and we started them on, Aricept or donepezil, and they improved to 22. So, how do you actually take that score on a test and equate that to someone's ability to function and be successful in their current environment, right? So there's a lot of room for ambiguity there. So we will generally, for a patient with Alzheimer's disease, ask a patient, would they like to start a medication? Is that something in line with their goals? We then look to see, can they tolerate taking a pill? Is there a huge pill burden due to other medical conditions? Maybe they're resistant to medication, maybe they don't want to. Then we look at their side effect profile. So I recently saw somebody that is losing weight in the setting of a mild to moderate Alzheimer's disease. And, one of the side effects of Aricept or donepezil is that it causes you to not feel hungry, and you lose weight and you can feel sick to your stomach. So in that case, we talked about it. We said, look, we're not recommending it at this time because, the risks of you continuing to lose weight and have a BMI of 17, is too great. We don't want to take the risk. Or maybe they have some cardiac conduction issues that it wouldn't be in line to give them an acetylcholinesterase inhibitor. Sometimes we see, increased urination, increased runny nose, increased salivation, and these side effects are very disruptive to individuals. And so we will offer and discuss, but we don't hesitate to not start or withdraw.
There's a question from Patricia Tanquery. Do you also test for COVID long haul with memory issues?
That's a great question, actually. That's a very, very, I'm glad that you asked that. Of course, we're asking about that more and more, especially in our cognitive or comprehensive geriatric assessment clinic. We have had a few people come in feeling like their cognitive issues started, very quickly or very quickly after an active, acute COVID infection. For some of these individuals, the cognitive complaint has actually lifted over a number of months, weeks to months. And for some individuals, it has persisted. And in a few of those cases, we've sent them to our neuropsychologist for further testing because they've been high functioning individuals who have noticed just some very subtle changes in cognition. And so we do send these individuals off for neuropsychological testing. And then we have also reached out to cognitive behavioral neurology to see if they can give some input into that.
Thank you for that. If I may, just for a moment, because I know I'm giving personal information, but my very smart retired physician husband went through all of this, almost died with COVID, ended up with 1.5 years of terrible vertigo and lots of memory loss, et cetera. The only thing that seemed to make a difference over time was verapamil. And but it took almost 3 years to recover. And not all, because he just turned 89. So some of it is age appropriate, but many of the really terrible memory loss did finally dissipate. So I just wanted to share that. Thank you.
Thank you for that. We actually have a ENT physician who specializes in vertigo and does use verapamil quite a bit. His treatment strategy for that. Yeah. And there've been some studies actually, small studies looking at changes related to COVID infection with cognition. I think one of them received a lot of press, talking about all of the changes seen on advanced imaging related to COVID infection and whatnot. So I think more to come. We probably need a lot more information about this.
Right. Thank you.
Nitu says, hi, Dr. Sehgal. Any
Hi,
suggestions to convince patients to use CPAP, especially if they have major neurocognitive disorder? Thank you.
Great question, Nitu. Gosh, that's a difficult one. All we can do is encourage, right? I'm impressed that the individual, if you're speaking about a patient, I'm impressed that they've gone through the testing. Often it's hard to get people to simply agree to even have a sleep study for a number of reasons, but, we encourage it as much as we can. I do have an individual who has a moderate major neurocognitive disorder, so a moderate dementia. He does become significantly hypoxic at night, cannot tolerate the CPAP. He actually worked with his sleep specialist to just get on oxygen at night. just to help improve his lower O2 sats during that time. So not perfect, but something. That is very challenging because it can be very, I mean, it's difficult for individuals who don't have cognitive impairment to keep the CPAP on.
From Clifford Nottingham, at what point are you willing to commit to recording a diagnosis of dementia in the patient's chart, especially considering the case of your patient whose cognitive status improved following the influenza and pneumonia?
Yeah, that's a great question. That is thank you very much for asking that. So often, you know, if in that individual, because I'm just thinking of him so keenly, we didn't say he had a major neurocognitive disorder. So this individual was hospitalized for a week, had pneumonia and influenza, came to me about 2 months after that. So he was hospitalized in December, and my first visit with him was in February, and he was obviously slower. He was slow on physical examination, and his wife, who happened to be an internist, was like, this wasn't him. I mean, this just isn't how he, you know, functioned in the past. He was also 85, he's 85 years old. So he has a lot of reason, you know, and risk factor, you know, he's accumulated some vascular risk. He's certainly of the age where he could have an acquired, you know, he could have Alzheimer's disease. So when I did my assessment in the chart, we listed it as cognitive impairment. We did not list it as dementia or Alzheimer's disease or anything like that. In fact, the picture was most consistent with a delirium, right? This hypoactive kind of delirium. So we wrote cognitive dysfunction. Differential diagnosis includes, you know, this prolonged delirium due to these infections. And we brought him back. And in his case, I think we brought him back every 6 weeks because his wife was very anxious about wanting him to be assessed and evaluated. And over a 4 or 5 month period, he slowly started to get better. But of course, during that time, we also made some medication adjustments. You know, he was on a medication for BPH and urinary incontinence. I think he was on oxybutynin or some like product. We stopped that. He was having some bradycardia related to a beta blocker that he was on for his heart. We addressed that with his cardiologist. So there were these very small things that we were fixing along the way that not necessarily were contributing 100% to his change in cognition, but were certainly kind of impacting and maybe prolonging his situation. So yeah, I don't necessarily feel like I don't have to commit to the diagnosis right away.
I don't see any other questions in the chat. I'm not sure if Nika is still available. She has put on the chat the evaluation link if you'd like to receive CME. And also, I think that if you needed to see this, also, again, if you wanted to watch the presentation, there's a YouTube link also. Nika, I'm not sure if you're there.
Oh, the video is, I can speak to that. So the session is recorded and you're welcome to watch that. We'll send the link with you, to you. And then please do use, let me see, the links in the chat for CME credit as well as for the session evaluation. Thank you all very much for participating today. I am so impressed that everyone joined despite being the day after Thanksgiving. Oh my God, I'm disoriented. 4th of July. And I hope that we'll see you in subsequent sessions. Thank you so very much.
Thank you, Dr. Stoll. This was
Thank
great.
you, Dr. Rahimi.
Thank you very much.